Hi.
Hi.
How are you?
Good. How are you?
Very well, thanks. I think this is where I'm supposed to go.
Yep.
All right.
You're in the right place.
Awesome. Hi. How are you?
How are you?
Very well, thanks.
All right. Okay, everyone, we are live and we're going to get going here pretty soon. So I have got a great speaker for you all today, a part of our CRH talks, and he's going to talk about knee replacement. A really popular topic. A lot of us, our knees go bad or we get in an accident and we need help. So Dr. Ryzewicz is one of our orthopedic specialists here, and I want to tell you just a little bit about him because he has a lot to his resume. He's fellowship trained in multiple orthopedic specialties, including shoulder replacement, hip and knee reconstruction, orthopedic sports medicine, and foot and ankle reconstruction. This guy's kind of got it all. So if you've got any aches, need new readjustments with your bones, this guy knows what he's doing, and so I'm going to have him come on. He's got a wonderful presentation planned for you. So let's go ahead and have Dr. Ryzewicz come on, and then at the end, we're going to have a couple of updates for you for upcoming CRH talks. And please make comments right now, because if you comment during our live video, your name will be put into a cool drawing. So let's go ahead and have Dr. Mark Ryzewicz.
All right. Well, thank you very much for having me here, Ashley. Thank you very much for having me here, Ashley. I'm in front of the camera instead of in front of a group, which is kind of a different experience for me, but I'll see how I do here. How do I is this the, so I hit the button here and it goes forward. Okay, good. Well, I think I can figure out the PowerPoint here.
Maybe stand right over here.
Right there? There?
Yeah.
There?
There you go.
Okay, perfect. Well, as Ashley said, I'm here to talk about one of our favorite things at the orthopedic clinic, which is knee replacements. Knee replacements are done basically for knee arthritis, which a lot of people ask, what is knee arthritis? And this is a little picture here to sort of explain why. This would be a normal knee. This is what your knee looked like when you were a teenager, perhaps. Nice, smooth cartilage surface. These surfaces glide nicely across each other, and they and generally very well and rather painlessly. This is sort of a depiction here of what happens as the wear and tear, as the knee just gets a little bit older. That cartilage surface wears down and becomes a little rough, doesn't move quite as smoothly, and becomes painful. This is an x-ray of what we would consider a normal knee, followed by a knee that has arthritis. You can see that the space between the bones here is preserved. There's space between the bones, and here we've completely lost it. That causes knee pain. Here we are. This is just a slide here just discussing the fact that knee arthritis is actually the #1 leading cause of disability on Earth. There is no condition that exists in humans that causes more physical disability on Earth than knee arthritis, and it's the 4th biggest cause of hospitalization in the United States. So, with the pain and the problems that knee arthritis causes, as you can imagine, the treatments for knee arthritis are really rather well known. There's no secrets when it comes to the treatment of knee arthritis. We can perform injections. There's things like stem cells are sort of a new trend, although unproven. There are arthritis pain medications. Some people like essential oils or braces, and these things probably have their role, but really what we're here to talk about is the ultimate treatment and the most well accepted and what we would call the definitive treatment for knee arthritis, which is knee replacement. So one of the first things that I want to talk about is knee replacement worthwhile? Does it work? And I think that one of the ways to examine that is from the patient perspective. And as a matter of fact, when you measure the patient perceived benefit from all these surgical interventions that are done in the world, the one that comes up second on the list of how valuable do patients think, how much benefit do patients think they're getting from the surgery, knee arthritis is actually number 2 on the list. Number 1, it turns out, is hip, but we're here to talk about knees today. Another thing that I found very interesting is the socialist healthcare systems in Scandinavia and other parts of the world. What they really focus on is the benefit to society of different medical interventions. And it turns out that one of the most beneficial procedures, or really interventions in all of medicine, from an economic standpoint to society, is knee replacement. This was a study that was done here in America, and the estimate is that our country is $12 billion richer because of the intervention of knee replacement. Now, that societal savings, the way that they benefit, the way that they've calculated it, is the benefit to society, which includes things like people's ability to work, decreasing disability payments, increased spending by an active patient. Those are considered benefits, whereas the costs are simply the cost of the procedure. That's how they calculated the value. And $12 billion per year in America is a pretty good number. As far as the individual patient, this has been studied, and on average, if you have a knee replacement versus if you don't, you end up in the long term $40,000 richer despite having gone through the operation. Certainly if you're 50 and you can return to work because of a knee replacement, then this number is a lot bigger. It's a lot smaller if you're not in that category of needing to return to work. But that's a pretty good number. This guy looks pretty happy. So knee replacement, as we've been discussing, is a very good operation to treat disability from knee arthritis. Not only do the patients think that or are perceived that they've gotten a lot better, but also we've got great economic impacts to society. So far we're talking about really pretty good things. But the thing about it is that when I was a resident at the University of Colorado from 2002 till 2007, and this is a picture of me a long time ago. Maybe I look a lot younger there, I don't know. But I absolutely hated knee replacements for those 5 years. And I want to talk a little bit about the reason why. It's because the residents, such as me, were in charge of taking care of those patients after the operation. And the thing about knee replacement is, although it's economically beneficial and it works out well in the long term, historically there have been some real challenges to it. And the biggest one, really in the short term, is pain. I'm going to separate these issues into the acute period, which is immediately after the operation. Subacute will be the first few months after surgery, and this applies to essentially all patients. The other thing I'm going to address are the folks that are still have some symptoms long term after their knee replacement. And this applied to a significant subset of patients that, as residents 15 years ago at University of Colorado, we were asked to deal with. We'll talk about some of the issues related to that and how we're addressing them today, a little bit better, we hope. So once again, I'm going over this the way that I'm breaking this down, which is the first few days after the surgery, the acute pain, the subacute, which is less pain, but still to some degree, and then we're going to talk about the long term, how the knee moves a little bit differently when you have a knee replacement compared to what people would consider their normal knee. So this is a knee replacement. These are photos of it. I guess they're kind of graphic. Some people might not like it, but I remember the first time that I saw it, I thought, oh my God, that doesn't seem like a good idea. And this is kind of, no wonder this is something that tends to happen. I don't know if any of you saw the movie The Princess Bride, but the group that we don't want to be, oops. Can you play this? You know, it's not that great a video, and I'm not sure exactly how to make it play, but it's a great scene from the movie, and if you've seen the movie, you probably know where the pirate ends up telling her that life is pain. Anybody who says differently is selling something. We don't want to be those guys. So historically, the immediate post-operative pain control is really provided just by the narcotic type of pain medications. And this is what we would give folks back at the University of Colorado about 15 years ago. I'm very pleased to be here reporting that this has really expanded tremendously, especially in the area of regional anesthesia, or what we call nerve blocks. Basically, this is the anatomy here, and what the principle of these is that you're going to block some of the pain signals that some of these nerves send back to the brain so that you can have the operation and hopefully not experience a lot of pain. This will improve the experience for patients, nurses, physical therapists, and limit the complications because the narcotics are not fantastic. This is what we want to avoid. We do not want to see people like this. And really the cornerstone of preventing that severe pain right after the operation is regional anesthesia, or the nerve blocks. When it comes to the knees, there are a couple different choices, and they have their benefits and their drawbacks. The femoral and sciatic, you can basically wake up with a numb leg and not feel any pain whatsoever with a successful block. The downside is that your muscles don't work until the block wears off. Different type of nerve block, you have a lot less pain, but it's still a little bit of pain, and but the muscles do still work. So there's sort of some cost-benefit thought about which kind of block you get. The regional anesthesia, the thing about it is that these blocks only last for a couple days, but that is generally enough for people to get through the acute period that we talked about, of when you get that face that looks like it's in terrible pain. That's the one we're trying to avoid in this acute period. The problem is that any block that completely relieves pain also blocks the motor function a little bit. But so my point basically is that these are fantastic for the acute pain directly after a knee replacement for the first couple days. We're going to move into the subacute pain afterwards shortly. The other thing that I want to mention, another sort of technique that has been used in order to alleviate that discomfort within the first couple days, is this is a medication that's now given to patients. Not all patients, because some patients have reasons why we can't give it, but all patients that can receive it get this tranexamic acid, and the thing that does is it reduces the bleeding. Now this is actually a pain relief thing because it prevents the knee from being full of blood after a knee operation, and that also significantly reduces the discomfort. So I think what we can safely say is that with the use of tranexamic acid and regional nerve blocks, in 2020 as opposed to years ago, the control of pain in that acute phase after knee replacement is usually very successful. Within the first couple days after the knee replacement with the blocks and the tranexamic acid, in most cases, that is not a significant problem like it used to be. This is physician's assistant Clint Merritt, one of the best PAs ever. And I'm not saying that just because I know him and like him. I'm going to move on now to that subacute pain, which is once the nerve block wears off and for the first few months of recovery. I think that this is the most challenging management aspect in modern knee replacement surgery. Really, in this phase, but it needs to be dealt with in this phase, because if it's a problem, it can limit the participation in the necessary rehabilitation after a knee replacement. People don't like the experience of being in pain, and you certainly don't want to talk about taking too many narcotics. This is from the New York Times. You'll notice 2005, so we're still talking historically. But the key thing about it is this is really a very common complaint that people have had, is for the first few months after they get their new knee. It's a lot of work. So how could we possibly address that? Couldn't we we talked about how sensory nerve blocks were fantastic in the acute period. Can't we make one that lasts a little bit longer? I mean, in that case, we would reduce this sort of subacute pain. But the key that we would also want to do is not block that motor function, those muscles that are necessary to really get that knee moving and working. Well, I have good news, which is that there is an idea out there that is very recent, within the last couple of years, which is freezing the nerve. We'll talk a little bit about that momentarily. This is sort of a history. A lot of times people say put ice on it, and this is something that goes back to before the time of Jesus, and goes all the way from that all the way to this company about 7 years ago decided to make a device that can actually temporarily freeze the sensory nerves to alleviate some of this pain. This is what the device looks like. It was approved in 2017 for the treatment of knee arthritis, and we'll talk just a little bit about that here. What it does is it applies a burst of nitrous oxide right around that sensory nerve, so it basically forms an icicle around the sensory nerve, which causes it not to work for a period of about 30 to 90 days. Once again, I want to focus on the fact that these are sensory nerves. You can't do this to motor nerves because you want them to keep working. This is what the device looks like here, and basically we put that device and target some of the nerves that provide sensation to the knee, so some of the ones that conduct pain, and knock those out. This is being used not only for knee arthritis. This is a thing here about, I was a college student at Stanford University in Palo Alto, and in Palo Alto, California, they have doctors there that are actually using this technique to treat migraine headaches. So that's kind of a different use for the same technology. Here we have Clint Merritt utilizing the cryotherapy device here on a patient. This is we're the only, as of now, or as of recently, we were the only practice in the state and also in the region utilizing this technique for patients before knee replacement surgery. The technique really is to treat this nerve right here that goes to the knee, which is just below the knee, as well as these two that are above the knee. So the questions any rational person would have is, does this technique work and is it safe? Well, the way we study these things in medicine is people do studies and they publish their results. This is a study out of New Orleans, probably the biggest one that's been done so far. The results here are promising. This is basically a measure of the treated group versus a control group, and this is a measure of how much pain the patients had afterwards, and as you can see, it was basically half as much pain. This is these are slides looking at the condition of the nerves during the course of treatment, and the bottom line is that all the nerves regenerated and started working well again after the few month period. So it does appear to be at least somewhat effective. Patients reporting half as much pain, and safe in that the nerve did eventually recover without long-term problems in that study. Now, one study in medicine is not really enough to convince the whole world that it's true and we're doing the right thing. So there are a number of clinical trials that are going on all around the country to sort of see if those results can be reproduced. I started doing it because this is a friend of mine who does over 600 knee replacements a year in Scottsdale, Arizona. Phoenix Magazine's very excited about him. They call him the Orthopedic Surgeon of the Year for their community. And he has been using it for a number of years for his patients. He's very enthusiastic about it. When I talked to him about a job down there, I ended up saying no, because I want to live in Cody and not in Phoenix. And I mean, that's my choice. I think it's an obvious one, but never mind. He wants to live there, but he got me into using this technique several years ago. So here we are. We're at the point now where we've treated nearly 200 patients with this technique preoperatively at Cody Regional Health Orthopedics. And my summary would be is that it does not make the procedure completely pain-free, but it does reduce the amount of pain reported. I think we can say that. This is a letter I got from one of our earlier patients, and he gave me permission to use it here. And he had 2 previous ACL reconstructions in the past. He reported them as being terrible for the amount of pain. He tells me that this has been very easy in comparison. So it's things like that that sort of make me believe. And right now, that's what we have is anecdotal evidence. Scientifically writing it up would be a nice thing for us to do, but for now, this is what we have. We've gotten some feedback from local physical therapists around the Bighorn Basin. One, I'm quoting right here, she told me, whatever you're doing, keep it up, because most people are doing remarkably well. So I said, thank you. We'll keep it up. This is the ad from the company on their brochure. They want to know, is iovera right for me? And this is an ad, yes, but we've done the procedures on a number of patients that have had knee replacements with and without the iovera cryoneurolysis. And the ad, I'll just say the ad isn't the only place where I've heard people say that they had knee surgery with and without, and the difference, the individual patients told me that they thought the difference was significant. I'll say not every patient has told me that, but a significant number have. The limitation of this technique is that the current protocol really only treats the anterior nerves of the knee joint. This nerve and that nerve, and they both serve the front of the knee. The problem with the posterior aspect of the knee is that, well, number one, it's not addressed with the current technique, but also those tend to be deeper nerves that are harder to reach, and also, as we talked about before, you can't really address the combined motor and sensory nerves with this because you don't want to knock out the motor function. So reducing it by half, you're getting the front but not the back. Maybe that's why it's 50%. So the future of this technique, well, we'd like to ask the question, can the protocol be improved? What are the results of these clinical trials going to be? Does it reduce costs and complications, produce shorter hospital stays? I think it has in our experience. Are patients going to demand it? As of right now, there are a handful of insurance companies out there that are not into this, but I'd say the majority are. We'll see how that develops over time. Questions about the technique? We're going to move on to talk about one of our last things, which is long-term outcome from total knee replacement. It's important to say that the knee replacement was originally an operation to improve crippling disability from knee arthritis. Historically, people that had knee arthritis really didn't have any option. They got to sit on the porch and hurt and not walk. This is not a desirable circumstance. The good news about being an American in 2020 is that you don't have to do this like people did in the past. But expectations and goals have changed. The historical, I talked earlier about not liking seeing the patients long-term after the knee replacement 15, 20 years ago. And that's because historically it was reported that up to 20% of patients were unsatisfied following their knee replacement. One of the main things that people complained about was inability for stair descent, going downstairs. And this is certainly something that if you're not just simply having the knee replacement for to avoid crippling pain and be able to walk around your house, but you actually want to do things with your knee, this is a big issue. And there's an underlying reason why, is that here we have the normal knee, and this is where the contact point when your knee is straight. When you bend your knee, that contact point is supposed to move back in a normal knee toward the posterior part. The thing that happened historically with knee replacements is that the initial contact point was here, and all the knees that were designed historically were rolling forward. And this made the knee feel unstable to patients, which is why things like going downstairs were very difficult. Now, in different patients, does that matter? Why do we care about that? Well, in the patient that's low demand, that is really just wants to walk around without crippling pain, these unstable knee kinematics might not matter. A patient like this, their muscles might be strong enough to make the knee work normally and not have that issue. The problem patient is this one, who's my mother. And she's the kind of patient that doesn't have the great big muscle where she can just dynamically control the way that her knee rolls. But on the other hand, it matters to her because she still wants to ski, she still wants to hike, she still wants to do everything that she couldn't do because of her knee arthritis. So how do we go about improving the kinematics of the knee after knee replacement surgery? Well, one idea has been to alter the surgical approach. This has actually been tried all around the world and been shown to make essentially no difference. The one thing I want to say is you can't do bad surgical technique. I did not do these, but I found pictures of badly done knee replacements. You don't want that. You want a good knee replacement. But the key thing I'm going to talk about here is the improved design of the implants. The implant is a femoral component, a tibial component, and a plastic spacer. I'm just going to go through this real quickly. The implants were, as I said, as they were going into flexion, instead of going backwards like a knee replacement is supposed to, the contact point was rolling forward. So what has happened is different companies have designed all kinds of different ways to change the way that this rolls. The one that seems to have the most promise has been the medial pivot knee design. And the key, I'll show you some key features about this in just a moment. The key thing with this is that it actually is stable in the medial side and it slides on the lateral side. This is different than the historical knees where there actually was not a right and a left. There were mirror images so that the inside of the knee was shaped the same as the outside of the knee in the traditional knee replacement design. This is a medial pivot design, and you can tell that here on the medial side it's much bigger and much deeper. On the lateral side it's much smaller and much flatter. This actually does resemble our normal knee much more so than the traditional one that didn't have differences between the medial and lateral side. The point is to keep the knee stable on the medial side and and as you go into flexion, have it slide back on the outside. Does it work? Well, this has been studied like a lot of things in medicine, and what this is showing here is that when you are doing some different things like level walking, going up ramps or stairs, the medial pivot design requires less work from your quadriceps in order to get those things done. The blue is the amount of force required from the quadricep to do these different activities with a medial pivot knee, and the yellow is with sort of an old-fashioned flat design knee. And you can see to do the same activity, the patients are using a lot more effort to do the same thing with the older knee design. This is a study from 2011. It's the first paper out there indicating that patients preferred the medial pivot total knee design compared to the more traditional designs. The other thing that's key is, okay, people prefer this, but is it going to last a long time? The amazing thing is that they found a 98.8 survivorship at 17 years. So that's a pretty big number. That's pretty good. You got people out there who will come in and they'll think, or they've been told someplace that a knee replacement is good for 10 years. This would speak to, it's a little bit better than that. So we talked about before how 20% of patients were unsatisfied with their knee because of a sense of instability. Here we're talking more like 95% of people like their knees as opposed to 80. That's really a very big difference. Here we have Terry Bradshaw. He has one of these knees, and he's become the spokesman for the medial pivot knee. He indicates that it's been life-challenging for him. He feels like it's a normal knee. One of my favorite things about practicing medicine in the Bighorn Basin in a smaller community is that I end up working on a lot of my friends, people that I know very well. I had a patient a few years ago who said he never thought he'd be able to make it back into his favorite fishing spot from when he was a kid. And I can see why, because we had to hike from the top here all the way down into the creek down there at the bottom. And here he is doing it with two knee replacements. So I couldn't keep up with him. I was pretty impressed. That was fun to see. I went hunting with another friend of mine. Beautiful elk, 2 knee replacements. Here he is carrying my quarters down off the mountain. I also helped him, but he was able to do it. He was able to pack out these quarters on his back with 2 knee replacements. He's actually just 5 months out from a knee replacement right there when he's helping me do that. I want to go back to my mom. Here she is before we replaced her knee. She was on a cane, couldn't play with her kids, couldn't do anything. And here she is. We talked about how people can't walk downstairs after a knee replacement historically. Here she is, 5 months out from her knee replacement. 5 months after knee replacement. So she's very happy. She went from a cane to 5 months later being able to do something that historically was considered impossible after knee replacement surgery. So I think that I was very happy to see that. So we're going to wrap up here. The last thing I want to say is one of the things I think we've done very well at Cody Regional Health is patient education. It's been shown out there that if people need an understanding of what they're getting into when they go into a knee replacement, and that managing expectations and knowing the expectations and what's going to be expected and what they're going to go through is very helpful. Reduces anxiety, really just makes the whole process more successful. And we've got that here. It's run here by, I have this picture here of, I spelled her name wrong. There's no S there. Denise Roach is the nurse that runs the joint replacement patient education program here at Cody Regional Health. Here she is in her native element, but just simply because I couldn't find a great picture of her out of her native element, because when she's not here, I think that she's always in an environment like that. So I just wanted to mention that and say thank you to Denise for helping our patients and being so excellent at this education aspect. So I want to end here with a summary, which is that knee replacement is an excellent operation at preventing disability from knee arthritis. It really is being used more and more successfully for enabling patients to live that active lifestyle without being hampered by pain from knee arthritis. I showed you examples of my mom and going and hiking down into canyons. I got to take some pictures next winter. Whenever I go skiing now up at Sleeping Giant, I almost always will see a patient or two that has a knee replacement on skiing. So that's exciting that people can do that kind of thing with an artificial joint. And usually they couldn't before because of the knee pain. We want to talk about how regional anesthetic nerve blocks are very effective for the acute pain after surgery. That really is a problem that's been very well dealt with most of the time. For that subacute pain for the first few months after surgery, that cryoneurolysis and freezing the nerve is something we're very excited about. We're also very excited about the therapy and the patient education as far as managing expectations for knowing making this phase of knee replacement much more successful and pleasant for patients. I talked about the stopping the bleeding into the knee with this medication here. This will also help the subacute phase because that blood that gets into the knee can sometimes cause some increased stiffness. We've made some progress toward resolving that problem. In the long term, I'm clearly a big fan of these medial pivot knee designs to achieve more optimal knee kinematics. I think a lot of the joint replacement companies are sort of recognizing this, and a lot of the bigger companies are sort of coming along with Me Too products, and some of them are going to work really nicely. It really has become a knee that's more stable and provides more function and satisfaction. And in that sense, the operation has provided a lot more value. So when we're talking about $40,000 in added value to U.S. society per knee replacement that's done, this number can be increased by either more efficient provision of the surgery or increasing the average benefit. So I think we're on target as far as achieving those goals for knee replacement in America. Thank you very much. I've said what I know.
So we've had a couple comments, but one, Carol Sutton, we're gonna call you out here. She said, she's had a knee replacement done about 18 years ago, and she fears that she's gonna need to have them done again. So what do you think is a good action? What steps should she take if she thinks she might need a new knee replacement?
Well, if you've had knees 18 years ago, certainly that was with a differing technology. And every knee that's been done that is having issues, you're going to need to identify specifically what those issues are, why you're having trouble, in order to identify what can be done. So unfortunately, there's really no way to answer the question as posed, because to do so, we'd have to examine the patient. We would have to obtain some diagnostic studies in order to identify what specific problem needed to be addressed to improve where she's at.
How do they get a hold of you?
They call the office, which is what is it? 307-586-2278 is, I think, a number that'll reach us.
578-2180.
That's another good one.
Okay.
Okay.
Right.
578-2180.
Okay, so go ahead and I'm gonna have you walk off that way.
Okay.
Okay.
All right, so Dr. Ryzewicz, thank you so much for being here. Thank you for those who have commented. You will be entered into a drawing. If you comment before I'm done talking, you also will be considered. So if you have any questions, please let us know. This video will be up long-term after this on YouTube and on our Facebook page. But we have upcoming CRH talks, hopefully with Dr. Ryzewicz and a couple of our other doctors. So just stay tuned at codyregionalhealth.org, and on our Facebook page, you'll see those coming up. And then we also have our upcoming Lunch and Learn with Dr. Lord from our Cancer Treatment Center. He's going to be talking on prostate cancer, about that and what you're going to have to be going through and what are the after effects of those different cancer treatments. That'll really help you out. So we're so blessed to have awesome providers here at Cody Regional Health willing to just share their time with us today. So thank you, Dr. Ryzewicz, and we will see you soon, everybody. Have a good rest of your day and a happy Labor Day weekend.